Hello everyone, my name is Gabriel Allaf and I am a psychiatry resident. Today I'll be presenting on the psychiatric aspects of rehabilitation medicine. Today's topic covers a lot of psychiatric challenges encountered in rehabilitation settings, particularly following stroke, traumatic brain injury, and spinal cord injury. Our focus will be on clinical patterns, psychiatric comorbidities, and management strategies. This domain requires both medical understanding and psychiatric insight, as mental health often determines rehabilitation success. Patients in rehab often experience major psychological stress. Depression, anxiety, and adjustment disorders are very common and can significantly impact motivation, adherence, and functional recovery. Without psychiatric support, these issues can delay progress and worsen outcomes. Rehabilitation teams must collaborate with psychiatry to address these factors early and effectively. TBI patients may exhibit mood changes, irritability, impulsivity, and disinhibition. Cognitive symptoms like poor memory and attention are also very common. They often lack insight into their impairments, which complicates their care. Depression, apathy, and increased substance misuse can develop due to neurological injury or the patient's psychological response to their new limitations. Major depression affects approximately 25 up to 50% of TBI survivors. Anxiety and PTSD are also common, especially in those who had a traumatic mechanism of injury or ICU stays. Substance use often predates the injury, but may also worsen post-injury. Some patients may develop mania or even psychosis as a result. Close monitoring for suicidality, impulsivity, and aggression is critical. SSRI antidepressants are often typically first line for post-TBI depression, for which sertraline is the most commonly used. Amantadine may help with apathy and cognitive slowing. Benzos are often discouraged due to their negative effects on cognition. For mood instability or aggression, mood stabilizers such as valproate or carbamazepine may also be appropriate. Start low and titrate cautiously as a general piece of practice. Post-stroke depression, or PSD, affects approximately 30 to up to 50% of survivors and impairs recovery. Emotional liability, apathy, and anxiety are also seen. Patients may suffer from cognitive decline or communication deficits that exacerbate psychiatric symptoms. Apathy is distinct from depression. It lacks the subjective distress, but still impairs the patient's motivation and engagement. Delirium is often under-recognized post-stroke, particularly with right-sided or parietal lesions. Symptoms include fluctuating attention, disorientation, and sometimes hallucinations. It is critical to rule out infection, medication side effects, or metabolic abnormalities. Using standardized screening tools like the Confusion Assessment Method, or CAM, to detect it early and intervene is crucial. So what is the treatment method for post-stroke depression? SSRIs reduce depressive symptoms and may improve functional outcomes or even survival. Fluoxetine, for example, has been studied for enhancing neuroplasticity. However, SSRIs must be used with caution in patients with hemorrhagic stroke due to bleeding risk. Psychotherapy and family support are important adjuncts to pharmacological treatment. Next are spinal cord injuries. Spinal cord injuries bring dramatic changes to identity, independence, and lifestyle. Depression, anxiety, grief, and PTSD are common. Pain and loss of physical function can lead to hopelessness or even suicidal ideation. Psychiatric support during early rehab helps prevent long-term complications and supports role adaptation, including around sexuality, caregiving, and independence. Chronic pain is common and strongly tied to mood symptoms after a spinal cord injury. Neuropathic pain increases depressive burden and limits rehabilitation potential. Opioids also carry risk for dependence, especially in patients with psychiatric history. Antidepressants like TCAs and SNRIs can treat both depression and pain. A multimodal pain management approach is necessary and crucial to the patient's future success. Adjustment disorders in rehab are also very common, as emotional distress is expected early after injury, but persistent or worsening symptoms may reflect adjustment disorder or major depression. Look at duration, trajectory, and level of functional impairment. Psychiatry consults help differentiate grief from pathology and help provide coping support, education, and family guidance. So, what is the role of psychotherapy in rehab? Well, psychotherapy is very essential. CBT and supportive therapy help reduce depressive symptoms and increase coping ability. Group therapy fosters social reintegration and combats isolation. In addition, family therapy improves communication and helps with planning for discharge and caregiving responsibilities. Therapy can also help enhance resiliency and self-efficacy. So, what are some psychiatric emergencies in rehab? Psychiatric emergencies can arise very unexpectedly, which include suicidal ideation, psychosis, or severe agitation. Patients with frontal lobe injuries may have poor impulse control. Those experiencing loss of autonomy may develop suicidality. So always assess risk. Ask about the patient's intent, plan, and means. Safety planning and close observation protocols should always be in place. In summary, psychiatric care is not a luxury. It is essential to functional recovery. Screen all rehab patients for depression, suicidality, anxiety, pain, and substance use. Close interdisciplinary collaboration between psychiatry, neurology, rehab medicine, and primary care provides the best outcomes. It is also important to remember that empathy, early intervention, and communication are very foundational to recovery. Thank you for joining my presentation today. Here are some references that I have used for my presentation and also for your own interest if wanting to pursue more information after this presentation. Thank you once again and enjoy the rest of your day.